So Mrs. B did fine. She was delirious. We treated her UTI. We restarted the benzo. We put her on some Tylenol. Her cardiac status actually stayed stable. She went back to her baseline cognition prior to discharge, and we discharged her on the same meds plus some Plavix and a higher dose of Lipitor. Now you see her about 8 weeks after discharge. Her daughter's still here with her, but she's going back to Alberta in a couple of weeks, and she's really concerned about her mom's memory and her ability to manage. So we're back at cognitive impairment. Acutely, we thought, could it be delirium? We treated that. Then the other thought process, is it subacute or chronic? And then when we look at that, we're going to look at it as a reversible, irreversible. Okay, so we've talked about the acute changes and the delirium. So now the question is this a subacute because we're 8 weeks out, it's back to baseline, but her mom, because her daughter, because she's been living with her mom, is kind of noticing some things going, wait a minute, you know, is this what's going on with mom? So again, talking to the family is the most important, to the patient and the family, but often patients aren't aware. So what is the time course of her cognitive change? So the daughter will say, well, you know, she had that acute worsening, but you know, she has had some issues maybe with remembering names of grandkids for a while now, or whatever it is. So what are some specific things that they're forgetting? So if you want to ask, you know, people will say, well, I have trouble with names. I have trouble with names. You know, I see some of my students here, I can't even name all of you guys, and I had you for, you know, 5 sessions. So I'm really bad at names, but if I'm forgetting the names of close family or people that I see all the time, then that's a concern. Appointments, medication, so if you're not filling your prescriptions on a regular basis, maybe missing appointments, asking the same question, that's a very common one. So people who ask the same question over and over, or they tell the same story over and over again. So some of you may know family members who, you know, you've chatted with them and then later on in the afternoon they kind of tell you the same story again when you're at some family gatherings. The other things that you should be asking about is visual hallucinations, unexplained falls, personality changes. Now why am I asking? I know you guys have had some lectures on dementia. Why am I asking about hallucinations, mobility issues, personality changes? Does that trigger anything for you guys for types of dementia? Lewy body for the falls, right? The mobility issue and hallucinations, right? And then frontal temporal for personality changes, right? So those are some of the key questions that we ask everybody that has a cognitive impairment once we're outside of that acute window. And then we always ask about safety issues. So, because these are things that we have to act on really fast. If they're leaving the stove on, if they're driving and getting lost or getting into accidents, if they're having problems taking their medication, if they have rotten food in their house, because the daughter's thinking, well, you know, mom doesn't even know how to make this anymore, she's burning stuff. Now that she's staying with her mom, she's recognizing all these things. And then the legal issues. So the earlier that the legal issues are done, the better. Once they're significantly cognitively impaired, they no longer legally can do that. It causes lots of problems with the family. The 10 warning signs of someone that might be developing dementia is that memory loss affects their day-to-day function. Again, it's short-term more than it is long-term. So they will remember tons of details from when people were younger. So people, you know, a lot of people are in denial about it because they're like, well, she can remember when I did this, and she can remember when I did that, and she can remember when she was in her 30s, but she can't remember what she had for breakfast, right? And the way I explain it to families is that it's almost like an ice cube. So you have all these memories that are forming, and they form over top and over top. And if an ice cube is melting, any of the new memories can't stick. The long-term memories are still on the inside, so we can still access those. Those connections are really, really strong, but we can't create new memories. So that's why I'll tell you a story, and then a half an hour later I'll tell you that same, oh, guess what happened? And I'll tell you the same story again because I forgot that I told you that story. And it's a story probably from when I was, you know, 20 years ago. Problems performing familiar tasks. So if your mom makes this delicious cake and she doesn't look at a recipe, she's made it a million times, and she starts messing that up, that's a concern, right? Those are things that she's been able to do for a long time. Things that, hobbies that they've been able to do. Whatever it is that they've been doing and can do well and something they can't do well, that's a concern. Problems with language. So it's often word finding difficulties. or else substituting words, so, describing something, you know, the thing that I comb my hair with rather than saying a comb or a brush. Disorientation, again, you know, when they getting lost in the city if you're from the farm, okay, well that happens to everyone. Getting lost driving back to the farm in your own town, that doesn't happen, right? So those are the abnormal things. Poor or decreased judgment, so wearing things that are inappropriate for weather, thinking that it's okay to eat cake for breakfast, things like that. Problems with abstract thinking, balancing checkbook. This is part of the Alzheimer's Society checklist. I've never balanced a checkbook, I don't know anybody who still does that, but that's on their list. Or not understanding what a birthday is. So really having like if you say, well, you know, it's so-and-so's birthday, and they're kind of looking at you like, they don't say, oh, well, how old are they? Or, you know, are you getting a gift, or asking the appropriate questions. Misplacing things, again, if I don't put my keys by my hook, by my door when I walk in the door, I have no idea what the keys are, which purse they're in, I don't know. But if I find my keys in the fridge, that's a concern, right? So it's misplacing things in inappropriate areas. Changes in mood or behavior, so a lot of fluctuations in mood are common as people develop dementia. Changes in personality, becoming withdrawn, inappropriate behavior, so changes from what they are. When you get older, you just become more of what you are. So if you're crotchety, you'll be more crotchety. If you're happy, you'll be more happy. If you're whatever, right? So you don't suddenly change. You can't say, well, they're old, that's why they're suddenly like that, right? Whatever you are is what you are. You just lose your filters, right? You don't care as much, and so you become more of what you are. And then loss of initiative. So that's a big one, is apathy. So it's people often confuse it with depression, and they're like, well, they just don't want to go to church anymore. They just don't want to go out and do this stuff anymore. They're not meeting with their friends anymore. So you'll get those types of things. Physical exam for a patient with cognitive impairment can be totally normal. So now we're looking into the more subacute area as well. You may have some focal neurological findings that might help you figure out what might be the underlying cause of change. So, of course, upgoing punches, you'd think, did they have a stroke, the vascular changes in their brain? If they have peripheral neuropathy, you would want to look at things like B12, which is more of a subacute change to your thinking. Reflexes are slow, you want to rule out hypothyroidism. And then your primitive reflexes will point more to very specific frontal atrophy or really advanced shrinkage in the brain. The cognitive test that we use when we're screening someone for cognitive impairment, the mini-cog should really be part of your normal neuro exam. So how many of you have heard of the mini-cog? Not the MoCA, it's not the mini-mental. So the mini-cog is, what they did was they took the most sensitive feature of the mini-mental for dementia, which is your 3-word recall. So I'm going to give you 3 words. I want you to say them back to me, and I want you to remember them for a little bit. So I always use the same 3 words because then I will remember because you'll give them the 3 words and then you have to come back to it and you're like, oh, I can't remember what the 3 words were. I use ball, flag, and tree, so they should be simple words. They should be, don't pick 3 colors or 3 animals. It should be 3 simple, different types of words. You want them to repeat it back to you. So if they say ball instead of ball, just go with that because that's a hearing thing. That's not a cognitive issue. So ball, flag, and tree, ask them to repeat it back to you, and then tell them, I want you to remember it for a bit later. Because no different than me saying, you know what, the CAM is probably going to be on your test. You guys will remember that a lot more than just what other random things that I've said today, right? So you want to tell them, and by the way, the CAM will probably be on your test. So you want to be able to say the 3 words, have them repeat it back to you. And what you're looking for is that they repeat all 3 back. The challenge always is to differentiate that they not get all 3 because they didn't hear you, or is it ball, flag, oh darn, I can't remember the 3rd one, right? So then you know that there's some abnormality there. That's the most sensitive marker on the mini-mental for an Alzheimer's type dementia because it's a memory test. So they pulled that out of that. And then the other test that we do is the clock drawing test. So you guys will get a lot of practice doing this because you'll have a skills day with me in 3rd year. But it's, you give a big circle on the page and you say, I want you to put all the numbers on the clock. Make it look like a clock. They put all the numbers on, and then you ask them for an abstract time. So I always ask for 10 after 11. That's what the studies have been used. Because a lot of people who are very concrete thinking, as they start developing dementia, will put it at the 10, right? You want 10 after 11, you want them to put it at the 2, but they have to process that. And there will be people who score perfect. You're having a conversation with them and you think, they are totally normal. And then they do the clock, and it's completely weird. Like you'll get all numbers on one side, I've seen people put a little 10 next to the 11, I'll see people write it out digitally, like it's the vascular part of their brain. So the clock drawing tests executive functioning. So this is your ability to plan, sequence, follow through with things. And anybody who's had vascular changes to their brain will probably have challenges with executive functioning. And this is kind of a quick early screen for that. So you do the 3-word recall. Say, I'm gonna give you 3 words, repeat them back, I'm gonna ask you a little bit later, get them to do the clock, and then ask for the 3 words. If they do completely fine on that, you're good to go. If they don't do well on that, have any problems, then you need to also add on the mini mental. Okay, so the mini mental again is Goldstein's mini mental. We'll go through this in detail. It is just a screening tool. It's no different than the history that you learn for chest pain. We go, okay, what's your pain like? Does it feel like pressure? Is it sharp? Does it hurt when you breathe in and out? Does it radiate? Does it go into your jaw? You kind of go through this series of questions. The mini mental is just a series of questions to help you decide which path you want to go. It's not a diagnostic tool. Just because they get a score on the mini mental does not mean that they have dementia. It's just a tool, right? It's just to aid your decision. So then you can do that. If people do really well on the mini mental, but they still might have some cognitive change that you're worried about, the MOCA is used for mild cognitive impairment. So these are people that have early signs and the mini mental is just too easy for them, or people with really high education levels that you need to challenge a little bit harder. You can do the MOCA with that. Okay, and again, you guys will get skills that you'll actually get to practice all of these, so you'll get a better sense of what they are.